Good afternoon, everybody. I do apologize. I think we're having some technical difficulties with the presenter, but we are working to get her on here as quickly as possible. But I'll go ahead and provide you all with an introduction to Lizzie, our presenter. Um, so she is going to be talking to us about the what's it called? Working with couples presenting with medical concerns. Ms. Lizee Love is an LMFTA associate, resident in AMFT. She uses she, her, ella pronouns, who is licensed to practice marriage and family therapy under supervision in North Carolina and Virginia. She's also a doctoral student at Virginia Tech in the Human Development Program with a concentration in marriage and family therapy. Currently, Lizzie maintains a small virtual caseload at Callahan Therapy and Consultation, where she works with couples with marginalized communities, LGBTQ+, BIPOC, neurodivergent, and chronic illness. Through Virginia Tech, Lizzie is an instructor, graduate research assistant, and doctoral MFT intern. During her master's program, Lizzie completed a medical family therapy internship at UT Southwestern in Texas, serving patients and families across primary care, secondary care, and outpatient mental health sites. Lizzie hopes to combine her clinical work and scholarship to achieve social justice and systemic change. So again, we'll wait for Ms. Lizzie to come about and get everything situated, and we'll be right back. So hang on. Hello,
Right.
hello, Ms. Lizzie Nuñez Love.
Hello, hello.
So yes, I already went ahead and preempted the audience with an introduction. So
Okay.
we're good to go there. So I'll go ahead and just give the floor up to you and take it on. I don't know, Hannah, do we have share capabilities? Do you need to share anything on screen?
Yeah, I've got some notes presented. Let me know if you're able to see that.
Yes, we sure can.
Fantastic. But I'm of course like more than happy to answer questions along the way. So feel free to drop those in chat or the Q&A box, whatever y'all typically do. But otherwise I'll just dive right in. It is so great to spend a little bit of time with y'all, and I am very sorry for the delay as well. Hopefully by the end of this, you'll have a little bit more of an expertise. I recognize some of your names from the MFT field, but regardless, you'll be able to engage partners into treatment of a patient, be able to identify some of the barriers that come with partner engagement, and then I'll also throw a couple of quick and dirty strategies as well for working with couples. So I'm super excited to dive in, but I want to be upfront with my theoretical grounding and what aligns the work that I have done in the past, as well as the work that I continue to do today. The first one is family systems theory, which many of you, I'm sure, have some familiarity with. But the two big ideas from this are the idea that an individual is grounded within their context. You aren't just seeing Lizzie today, you're seeing Lizzie, the PhD student, the spouse, the cat mom, the person who deals with some sleep problems too. And that informs how I show up and how any other individual shows up as well as the idea that the sum is greater than any of its parts. The whole is greater than the sum of the parts. That's another part of family systems theory as well. The next piece of this is circular causality. Rather than A causing B, A and B are mutually reinforcing with each other. So you might often think, I have an alcohol problem, I have a drinking problem, and so I drink, and then I wake up the next morning with back problems because of the inflammation, where instead it might look something more like I have a history of chronic back problems, and so I drink to self-soothe, I drink for some of the stress, and then I wake up with back problems as well, and that's mutually reinforcing itself. And a final thing underlying some of the work that I do is attachment theory, which is the idea that a child's early relationship with their caregiver, seeing that responsiveness from the caregiver is going to inform how they show up in their adult relationships. And also, more importantly, the ability to have like a secure, safe sounding, whether that is in our adult relationships, our friendships, our partnerships, is going to be pretty fundamental to healing. So some problems I imagine you'll have encountered in your work with couples is that you're busy. You've got limited time. Having more people in your office, more people in the room, means that you're then having to navigate more concerns and take away from that time out of your busy day too. There's also the idea of how you address the patient themselves versus their partner, how much to include the partner's input in the treatment that you are delivering or the care too. There also comes the idea of confidentiality. I have certainly gotten a call multiple times from a patient's spouse or caregiver, and they're wanting to ask questions, and I'm like, oh, I'm sorry, I can't confirm or deny because I don't have a release on file. Um, then there comes up of issues of power, whether that's in the partnership itself, in the couple itself, or in the provider-patient relationship too. The idea of who is holding power in the room, how do we navigate conversations around power, and then finally, who is making the medical decisions after all? So what? Why involve partners in the first place when we could make it so much more easier just one-on-one with you and the patient? There increasing your understanding, being able to work with couples, being able to incorporate partners too, increases the patient's outcomes and increases the support from the family as well. You get more treatment compliance, more treatment adherence, and then this also increases the family relationships too. Often I've seen conflicts or arguments around a patient's decision for medical care, or, oh, you don't take your blood pressure medication. Why don't you ever take your blood pressure medication? And having the buy-in, having the involvement from the partner themselves can really help to support that and have some of those conversations openly. In addition to that, having like an increased understanding of the illness and the treatment plan means that you don't have the patient and their family members or partners having these conversations, turning to Dr. Google, um, and making these decisions outside of your expertise or the office. And then you also have more social and emotional support for the patient, which can help with their treatment outcomes too. And then finally, this really aligns with the mission of CFHA as well. This idea of providing patients and their families optimal, fully integrated experience in the pursuit of health and healing. And I'm a big believer that relationships are a pretty integral part of that healing process too. So to throw a couple stats your way, 69% of American adults are partnered. I'm sure that applies to many of us in the Zoom call as well. And then we also see in sickness and in health as a part of wedding vows in North America. And this idea that we are with our partners when we've made a commitment to somebody that occurs through the different phases of life, whether someone is healthy and at their full capacity, or throughout the course of illness or the lifespan too. And another stat to throw your way is that in the United States, there are 47.9 million people serving as caregivers, and about 12% of that population are spouses. Spouses and spousal caregiving have a few additional risk factors beyond typical caregiving. There's a higher emotional intensity when a spouse or a partner is caregiving. There is this change, the shift in roles from partner and partner to caregiver and care recipient. Um, Another factor of this is that about two-thirds of this population are providing unpaid care or they do not receive paid help, which is in contrast to the 36% of families who do rely on paid help. And often spousal caregivers are not eligible for any kind of governmental financial support. Another piece of this is that spousal caregiving often lasts longer than non-spousal caregiving, whether it is a parent, an adult child, or an outside family member, friend, or a paid caregiver providing the help. Um, Most of this, or a good chunk of this, will last longer than 5 years as well. And then when a spouse is serving in the role of caregiver, there is an increased impact to caregiving on their mental and physical health as well. So I'd love to throw a question out to the group of you. Feel free to drop it in the chat or unmute and speak it too. But what comes up whenever you're thinking about working with partners? What emotions come up? What scenarios? What fear or things that you've already experienced come up when you think of bringing them into the room? I know for me, there was a lot of fear at first. Stephanie said, ensuring both partners feel heard and validated. Rylan said, being prepared to intervene during high conflict. There's also confidentiality from Jinsuk. Yeah, absolutely. Absolutely, absolutely. Thank you all. How much loyalty do I show to the partner? Ashley said curiosity around what dynamic will be present. Sometimes they'll come in hot. Sometimes they'll come in. Sometimes you'll have different opinions about what the treatment or the course of care will look like too. Awesome. So some ideas about working with couples one-on-one. A mentor of mine said go slow to go fast in working with couples. Often couples will come in hot, they'll come in with big ideas and big feelings about what's going to happen, or oh, they said this, or this is the route we need to take. But the ability to slow down, the ability to take, okay, what is happening here? What is going on between the two of you? Can make that monumental difference. That small change, that small shift in their dynamic can have bigger implications as well. Another piece is be clear about your role as a provider. Often your job is not to take sides. Your job is not to say who is right or who is wrong, but rather to provide information based on your role and based on the decisions of making care. So if you are a pharmacist coming in and talking about medications and the different options and different routes, and someone is wanting one medication over the other, you aren't the goalkeeper, the scorekeeper here, but rather to give them enough information to have clarity. Whereas if you're a physician and you've got someone who maybe also works in the medical field wanting to say, or Dr. Google tells me this instead, your role is not to be that timekeeper as well, but rather to be the informant. And then also, it is more than okay to refer to behavioral health or outpatient couples counseling if needed. If things are getting pretty hot, it is okay to say, hey, do y'all have someone to talk about this? Or I am noticing a lot of relationship conflict coming up between y'all. You talk about your spouse or your partner, and this seems really hard. Like, do you want me to get more support, more connection for y'all? Um, it's there for a reason, and your job isn't to balance each of these plates as well, even when you're integrating couples care into the work that you're doing. So to start, whenever the couple walks into the room, that's this great place to get a sense of the dynamic and then also to initiate how you're going to engage in care with them as well. Consider cultural considerations. So, in some families, this might look like greeting the patriarch first or the matriarch first. This might look like greeting the oldest person in the family. Be mindful of the background that your patient is coming with when initiating greetings. But generally, I would recommend greeting your patient first. Hello, Miss Jones. How are you? How's it going? How are you doing since the last time I've seen you? And then the next piece is to ask the patient to introduce their partner to you. Don't assume, don't make the same mistake I did once of asking siblings if they were partners. Yeah, I see some nods in chat. Um, Let them introduce themselves and their role to you. Or you can ask the partner themselves. Hey, nice to meet you. What's your name? How are you related to Miss Jones? What brings you in today? That what is said about the role will tell you a lot, and then also what is unsaid about the role can tell you a lot. If Mr. Jones says, I'm Mr. Jones, nice to meet you too. That's going to tell you a little bit about how he's doing if he's not engaging with you. Whereas if somebody is the one to introduce themselves and ask all the questions and interrupt the patient as well, you're learning a little bit about the dynamic between the two of them, which I know some of you had mentioned in the chat as well. The next piece of this is confidentiality. As providers who are connected through technology currently, many of us are following the standards of HIPAA, ensuring we're compliant with HIPAA as well. And so the best way to navigate confidentiality is to have a conversation with the patient and ideally with their partner present about how they want to navigate the patient's treatment, and then to have a release of information on file. I have had a phone call where a spouse had called up about charges made on their credit card, had pulled up the patient's file, and I was like, oh no, I can't say anything to you, just in terms of best practice. And of course, HIPAA does allow conversations around coordination of care, around paying for treatment too. But under the guidance of my supervisor, we had to contact the patient first, ensure they wanted us to be able to speak with their spouse and say, hey, if you're using their credit card, we got to talk to them too. And it ended up being okay. We were able to navigate it, but best practice, make sure you get that release on file, of course. And then talk about it. Like, who is caregiving? Who else is involved in the patient's family, involved in their larger system? What other stressors or supports do they have too? Do they want adult children or parents to be involved as well beyond the support of the partner? Are there people they don't want? Of course, this is part of the practice too, but you're going to get more information when you're talking to the partner as well, around who is involved in care, who can we involve in care, um, and what that looks like in terms of supporting the patient. And then finally, emphasize that we are a team. We're supporting the patient's care together. We are making these decisions as a collaborative unit in order to get the best source of health for the patient. So the next piece is power and ethical decision making. Kitchener describes 5 ethical principles of autonomy, the idea that a patient has a right to make decisions for themselves about their care, including discontinuing care. Beneficence, the idea of doing good, making sure the benefits outweigh the harm. Non-maleficence, which is the idea of do no harm, very important, especially in the medical field, of that we're not doing treatment decisions that will harm the patient. Justice, the idea that each person has a fair, equal, and equitable opportunity for care. And then finally, fidelity, which is the idea of faithfulness. And the way I see this in terms of treatment, is adherence to best practices, keeping up, continuing education, like we're doing currently, and maintaining that understanding of care. Um, when it comes to operating ethically, you're going to get conflicts in terms of treatment. In my master's internship, I worked with patients in the neurology unit who had ALS or Lou Gehrig's syndrome, and their partners or family members. And often I would have conflicting decisions between the patient and their loved ones about what course of treatment they wanted, if they wanted to continue treatment at all. So consider how you would balance ideas about the patient wanting to discontinue care, whether that is for a terminal illness or a course of cancer or concerns around payment versus their spouse or loved one saying, no, 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 do the clinical trials, continue, try this medicine, try this other treatment instead, and how to weigh the decisions of people as well. Another piece is asking and ensuring the patient and their partner have their concerns heard. What are their concerns about this course of treatment? What is their understanding of the illness itself? Are they on the same page about what they know, what the prognosis looks like, what the different treatment options look like? And then how confident and sure are both the patient and the partner in their ability to implement treatment and their ability to sustain care? Um, because again, Dr. Google is very powerful, Dr. ChatGPT too. And so to be able to have that conversation in your office, to be able to facilitate that conversation, is extremely important and really speaks to your ability to implement your expertise and your knowledge about the condition. I had mentioned this earlier, but being able to clarify your role as a provider, this is going to depend on the treatment that you're providing to the patient and their partner as well. Um, Another piece of this too is concerns about power or abuse. Of course, in your role as a mandatory reporter, that is one element of it. If you're concerned about a disabled or dependent or older adult being abused, but it's important to be able to separate them privately if you've got concerns. I remember one time I had met with a patient and their spouse. And I had noticed that the spouse was very critical of the patient. Everything he did when he had come in his wheelchair and had bumped into the wall, she was criticizing him. And so I separated them and I said, hey, this is just a normal part. I really enjoy working with couples. I love supporting patients and their family. But a standard part of my practice is to meet with each of you individually, just so I can get a better sense of your concerns and needs, hear out what's going on. And they agreed, they understood. And when I separated them as well, I had met with the patient first and I said, hey, I have some concerns about what's going on. I noticed this is happening with your spouse. Like, what's going on here? And he said, oh, nothing, nothing, nothing. And then I had met with the spouse privately, and she had shared that there was a history of abuse prior to the course of the illness where he had been abusing her. And so we explored that a little bit and what it was like for her to be the caretaker. Um, and we're able to talk more about this, and then work towards talking a little more openly in their care as well. So another piece of this is too many cooks in the dang kitchen. When you have multiple people in the room, you've got multiple opinions, multiple feelings, multiple ideas about what the course of treatment is going to look like. Um, what I would recommend is being able to empathize with each partner, each person in the room. Um, I understand you are wanting you love and you care about your partner. It's so hard to see them hurting like this, and you're wanting to see if they'll try out these clinical trials to see if we can get a different course of the illness. Whereas for you, patient, I understand completely. You're exhausted, you're tired, you have been in and out of the hospital for years, and you are wanting to stop and rest and live out the rest of your life in the best way that you can. If you notice a little bit about what I've said, I'm trying to get to that underlying emotion, that fear of loss, that anxiety about what's going to happen, about the worst case scenario. Often the fear of being alone, whether that is the patient themselves of not having the support of their partner, or the partner as well with the loss of the patient. Um, as I had mentioned, this had come up quite a bit in my work with patients with ALS and making decisions about end of life care. And it is also the ability to hear somebody, to empathize, and then to turn to their partner and say, "What was it like to hear them say that? How was that?" And they'll share, "Oh, it's hard. Like I get where they're coming from," or "Oh, that they've said this to me. They're saying it to you. I get it, but I don't agree." And just really opening that line of dialogue, being able to get that clarity in the room between the partners themselves too. Another piece is let's actually blow the roof off this kitchen and get more cooks in here too. Ask about who else is in the couple's life. Do they have children? Do they have parents or in-laws? Do they have friends? What does their spiritual, religious, or other community look like? What do their pets look like? Each of these additional members of the family of the system will also inform who can step in to offer additional support, who can step in to offer additional care, or who or what is adding additional stressors to the life. you might find concerns about what will happen to my pets if I die. What will happen to our children if I get sick? And it's just you relying on them too and taking care of me. Um, I had worked with a patient who had multiple sclerosis, and he was in there with his wife, his brother, and his young son. And he had talked about feeling like a burden for the entirety of his life, and especially with young kids, and not being able to pick his children up and hug them and spend time with them. And we had had a really beautiful and impactful moment where I had asked him, "Hey, can you tell your son I wish I could, and I love you, and it's hard to be vulnerable, but I want you to be able to be vulnerable too." And it was incredible to be able to witness that, and to also see the extra role that playing a parent, in addition to being a spouse, had had on this patient's life. Um, and sometimes, if depending on the site or the setting that you're at, you might have a behavioral health provider or behavioral health specialist, um, a counselor or a social worker or a marriage and family therapist or a psychologist. Depending on the setting, you might ask them to step in too. Hey, I have a patient who is crying and crying and crying. Um, can you help them out? Or, hey, my patient has mentioned having thoughts of wanting to die. They are talking about suicide. Can you go in and can you assess? Depending on your role, bring in your team, lean on your team as well. Just as the patient is operating within their community, that is the same for you too as a provider. So another element to consider, whether you're working with the patient or you're working with the couple themselves, is this idea of caregiver burnout, where the caregiver is experiencing overwhelming grief, loss, stress, exhaustion. It's showing up in their, excuse me, mental or emotional health as well. Um, and this can occur regardless of who in the family that you're working with. So it's important to check in on how the caregiver is doing. I've found that the best way to do this is to directly ask, how are you navigating care? Are you feeling burnt out? What is your stress like? What is your support system like? Because often there is this change in the transition to the role of caregiver, where the future that the caregiver had imagined with their partner, whether it is earlier in life or at the end of life, is changed. There's grief that comes along with seeing changes in their partner's health or ability level. And often there's changes in other relationships too, both inside and outside the family, where maybe we can't hang out with our friend group in the way that we used to. We can't go out to Friday night board games in the way that we used to because of care needs, or the bathroom at the bar doesn't have accessible toileting options. Another piece of this is that some data had shown an association with caregiver stress and burnout on increased costs and increased utility of the healthcare system. So, if we're able to check in on the caregiver and get them connected with services, get them connected with care, or even just spend 5 minutes talking to them a little bit, that can reduce a little bit of the burden on the health system itself. Um, and yeah, that can just look like a quick 5 minute, how are you doing? Tell me. Or a phone call, or saying to the patient, hey, can you call up your partner? Let's talk to them too, depending on the time and the ability that you've got as well in your setting. And the next piece, I would argue probably one of the most important pieces too, is provider burnout. What you are doing, the work you are doing is hard. And often we come into medicine and to caregiving fields with the idea of to help, to fix, to treat, to change, um, which you can't always do in the context of difficult couple work. Um, Instead, the goal here, the idea here is to provide clarity, to provide information for the couple, the family to make informed decisions about what care will look like. Um, Another piece of this that I've seen both in terms of doing couples work and in interfacing with the medical system is that coming close to couple problems can illuminate things about your own life too. So when you see themes show up in the patients or in the couples that you're working with, that can shed light on what's happening for you too as the provider, and that is stressful. It's super stressful. Um, so I would absolutely encourage you to take care of your needs, lean on your team, take breaks, take time off when it allows, use the full spectrum of benefits that are offered by whatever setting you're working at, and nurture yourself too, because providing care is difficult on any side of the system as well. And when we're working with couples, when we're working with multiple people, it is especially hard. Um, this is the extent of what I've got. So just some final thoughts that I hope you're able to take away, and then I'll open it up for more questions or conversation too. Is involve the partner when possible. This is going to improve outcomes for your patient, compliance with treatment, understanding of treatment and what's going on. Lean on your team, lean on other elements of the system in which you are operating, and then practice ethically with those five principles, often conflicting principles, and systemically too. Um, Yeah, what questions are coming up for you? What concerns have you run into yourself? Let's chat a little bit.
Hi, everyone. I can jump in. My name's Karima. I am a behavioral health consultant in a primary care behavioral health FQHC. My concern is always around the time frame. I'm worrying about how am I going to address couples thing in a short, brief session, 30-minute session. So if you could speak a little bit to condensing things, focusing things, maybe making it clear we have 30 minutes today. If you need more intensive work, maybe you can be referred to a couple specialists. But I always get really nervous kind of going into the sessions about the time parameters around BHC visits in primary care.
Yeah, absolutely. Thank you, Karima. I think exactly what you said is the frame to go in with. You start and you say, hey, we have 25, 30 minutes here. It's a short amount of time, but let's pack as much as we can into it. What is the one thing we're wanting to get out of our work here today? And let the patient and their partners self-define their goals for you. What is the one thing they want to do? Hey, we want to talk about compliance with blood pressure medication. Or hey, we keep arguing about this decision of whether we should move or not. That's going to mean completely uprooting ourselves from this system into this one. So let's start that conversation. And I struggle with this myself, but of course, make sure you've got your little time clock behind you and your little time clock in front of you. I've got mine on my laptop. And give the patient heads up. Hey, we've got 15 minutes left. We're about halfway through our session. Have we gotten to what we wanted to talk about today? And I've also noticed this piece too, that I've worked a lot in supervision, which is interrupting. Hey, you have said you're not saying this, but you've said the same thing over and over again. I really hear you talking about the importance and the fear you have about your partner not taking medication. Partner, what are you hearing from this too? So I'm interrupting, I'm summarizing, I'm not asking them a question to check in with them. I'm checking in with the person next instead. Um, and then check in again at the 5 minutes. Hey, we're coming up to 5 minutes here. What's something we want to end on? We've talked about a lot today. Um, what is a takeaway that you've got that you want to implement here? Or do you feel like you're getting your needs met, or should we talk a little bit about getting you a referral to an outpatient setting? Karima, does that answer your piece about the time frame? Do you have more
Yes,
questions?
that's super helpful, especially with the last, like we have 5 minutes left. How do we want to end our session or how do we want to wrap up our time together? I love that as well too. Thank you.
Absolutely. Absolutely. Something I've started saying, which I love, but I always get like question marks for eyes whenever I throw it out there is what word, image, or phrase do we want to end our time on? I'll get a color, compromise. I'm wanting to channel the people doing Tai Chi on the beach. I think each of those can be pretty great to wrap up or get the distilled essence of whatever our session was. I see something in the chat. When Jean said, I wanted to ask about situations where, because of cultural norms, one spouse answers for the other, like a husband speaking for the wife, and there's also an interpreter involved. How do you approach that when you want to make sure the patient's own voice and needs are heard? That is a fantastic question. And I want to separate out the two pieces, the piece about cultural norms and then the piece about when the interpreter is involved, because I think there's considerations for each of these. Um, for cultural norms, I would suggest it's hard. It's hard. I'm feeling this even in myself now of striking that balance between aligning with the cultural norms, greeting the husband first if that is the norm, and then also checking in with the patient. So you've asked a question or you've posed a thing about, hey, you have a UTI, so I'm going to prescribe this antibiotic. What pharmacy do you want me to send it to? And the husband says, oh, the one on University Street. And so you might say, okay, thank you. And then maybe turn to the wife. University Street is the correct one, right? And then you'll get an understanding from her too. Um, Another piece of cultural consideration of making sure the patient's own voice and needs are heard. If you're able to, implementing that separation between saying, hey, I'd like to meet with just the spouse for a little bit and just the patient for a little bit and take about 5-10 minutes with each person to check in to say, hey, I know your husband has mentioned this and these are their concerns and this is the way y'all are wanting to do. Does that feel right, or do you have any other different things? Or I noticed you've hesitated. So I just wanted to make sure, are we getting all of your needs met here too? Um, I had worked as an administrator for a private practice setting, and we had a couple come in where the husband was wanting to be the primary point for the scheduling and the payment for his wife. And I'd said, yes, absolutely. We just need to get this paperwork set up. We need to make sure we have a release of information on file to ensure, just because these are the standard practices and clinic policy as well. And for your piece about the interpreter, I think this comes in with the piece of time too, because when you've got an interpreter involved, um, it's extending the time of your appointment, but your calendar time, your appointment time does not change. The number of blocks you've got scheduled in the day does not change as well. Um, so my recommendations is not to do what I've done here today and speak without any commas or periods. Say one sentence at a time and pause. Let the interpreter speak. Um, if your setting allows you to, if you're able to, if you've got interpreters either on site, which I know many don't, try and do a pre-brief and a post-brief with the interpreter of, hey, I have a patient coming in today. These are the concerns we're going to discuss. These are the concerns I might have about ensuring the understanding here. And a post-brief as well. How is that for you as the interpreter? How are you feeling? Um, I speak very poor basic Spanish, and I had worked with a patient and her mother who were Spanish speaking only. And so I knew enough casual language to see, oh, this interpreter's kind of cutting corners here. They're not saying exactly what the patient is saying to me. And so we'd use a lot of my nonverbal language too, of nodding while they were speaking, making eye contact when they were speaking, and then waiting to hear the interpreter, asking follow-up questions. But of course, I know this is all within the context of the time and the limited time that you've got in your setting too. So I hope that is helpful. Adrian said, thank you for this. I'm a behavioral health provider at a family medicine clinic. I enjoy involving the family in care decisions, but I recognize it can cause conflict when the partner does not feel like the patient is doing what they are supposed to for their health. Physician recommendations can become fodder for an argument, which can make a patient feel blamed and shut down. How do you approach these situations? Yes, absolutely. Physician recommendations can be another point of criticism. You're not listening to your doctor. Your doctor has recommended you take these medications, and you're still not taking these medications. Um, Depending on the relationship that you have with the patient and with their partner, you can name it. Hey, I noticed that this is coming up. Hey, Ms. Jones, I see you starting to shut down. I see you starting um, to speak a little bit less. What's coming up for you? Um, if you don't have the rapport with them as well, that might look like, hey, it's important that we hear these recommendations from um, the doctor, and we also can't take these home. We've got the autonomy here. We're adults here making decisions, and we know this. But let's talk about what's getting in the way of this. What's coming up. Um, and often you'll see that circular causality piece where the criticism will come, and then the patient might not do the recommendations, and then the criticism comes, and it's reinforcing itself. So whether you can name the dynamic that's going on, you can ask the patient directly, or splitting sometimes too to see what's the fear of the person making the criticisms and what's the fear of the patient keeping them from following those recommendations. Those are each ways to potentially approach that as well. I hope that is helpful. Stephanie said, on the opposite side, I am a licensed associate marriage and family therapist at a private practice with an interest in working with couples and clients with medical trauma and chronic health concerns. How can the outpatient private practice care team better support the client and family caregivers with respect to their medical concerns? Excellent question. That is a really excellent question. I think you can tackle this from multiple different ways. One of which is just to build relationships with other providers in your area, build relationships with physicians, social workers in the area, hospitals in the area. Hospital social workers will be your best friends, and then eventually your best referral sources too. Um, and then also build relationships with the individual providers and collaborate on care. So if you're working with a patient or a client, and they're also meeting with a psychiatrist, say, hey, can I get a release of information to speak with that psychiatrist? And then you can either send a letter, send an email, call up the psychiatrist, set up a Zoom call, to meet with them and say, hey, these are some of the concerns I've noticed with my client, and some of the things, some of the symptoms that are cropping up, even in response to this medication. What do you think? What are you seeing? And another piece of this, in your work of an outpatient therapist is helping to guide your patient in advocating for themselves, helping to guide the partner too in advocating for themselves. Are they clear about what condition or chronic health concern they have? Are they clear about what their treatment options are? All their alternative treatments? Do they need a second opinion? And being able to role play in session or engage with your patient on what those concerns are and how they can have those conversations with their other medical providers too. Those are a couple of ideas that come up um, on the private practice side of things. Rylan asked, when working in a medical setting, are you recording documentation in both patient's client's medical record, or do you just have one identified patient? Are you getting consent forms signed from each in a medical setting? That's a great question, Rylan. And this is like a conflict that can come up with systemic work, and the way that our medical systems are set up too. It's going to depend on your specific setting. So check with administrator, other providers too. But typically what I have done, is I'm just documenting in the identified patients file. I met with Ms. Jones, her husband was present too. We discussed relationship concerns. This is what came up. Behavioral health specialist made referral to couples counseling. Um, this is not the case in outpatient setting where you'll have like a couples chart. And it's going to depend on your setting too, but generally I do have the identified patient when making documentation. And then as far as are you getting consent forms signed from each in a medical setting? Um, Typically, I have not, but of course, that'll depend on your setting as well. In some of the settings I've worked with, we'll have a forget what the term is, collateral. They'll sign a form saying like, I am here to support the patient in their treatment, but I am not the patient as well. I've sometimes seen a release of information signed for the other person of like, hey, I am the patient is releasing information to speak about their care here. But generally, it's just come on in, and then I'll document in my patient's chart. But of course, it'll vary depending on the practice of your system, or maybe you're setting up the system yourself too.
Thank you. Sorry, I just wanted to add on to that, and it would be more complex to write, but just I've never had this happen, but I always wonder, I've always used the identified patient as well in the medical setting, but I wonder like if someone was to request the records, one of the spouses and the other one didn't consent, that whole issue, if it's only in one person's chart, but like, you know, I don't know how to reconcile that. So
Yeah.
just wondered if you had any thoughts, but I definitely appreciate what you shared.
Yeah, absolutely. Um, this depends on state law too. I am licensed in North Carolina and Virginia. I believe in North Carolina, anyone being treated can sign and get their records released, whereas in Virginia, you need all parties to sign. Um, I think, and of course, I'm not a legal expert too, so take please what I say with a huge, huge grain of salt. That's what that collateral form can be helpful for, of like, I am not the patient in this setting, therefore the patient has to be able to release the records themselves. Um, but it really just depends on what your state laws are specifically, and how the setup of your system. So I know that's like a non-answer, but I hope that helps a little bit of guidance. Patricia said, I often talk to patients about blocking couple notes, and most have accepted my recommendation. Great, great suggestion too. Yes, awesome. I see some people are starting to sign out. I am happy to hang on for the next 5 minutes, but I know y'all are busy. You need time to get a bio break. So thank you all for your time. If you've got any more questions, I'm happy to chat. I'm happy to connect. But yeah, I really appreciate it. Thank you all. And thank you, Misty, and the rest of CFHA for having me here. This has been great. Thank you, thank you, thank you. I'll stop screen sharing.
We really appreciate you coming out, Lindsay or Lizzie, and presenting for us today. Thank you for your time, for your expertise in this area. If anybody else has any questions or comments, please go ahead and ask Lizzie or any one of us here.
Lizzie, out of just curiosity, what is your like research area or kind of like dissertation topic?
Yeah, thank you. I am studying social justice in MFT training. So I'm wanting to see how are new therapists being trained, what attention to DEI they're getting in our current context, how are trainers kind of navigating the tension between state and national legislation versus kind of best practices, ethical guidelines. That's what I'm really, really interested in.
That's awesome. I have a friend at one of the colleges in San Diego. I don't think it's his University of San Diego. I think it's the other one. Um, and she actually has a very similar kind of like research area. Um, if you want me to, I can connect y'all via email just to kind of facilitate a little bit of that. Um, I think, I know published some on that, and I think part of her dissertation was on a kind of a similar topic. So I think you all would have a lot in common.
I would love the connection. Is she at Alliant by any chance?
I don't think so.
Okay.
That's a good question though. She could be at Alliant. I just saw her in San Diego a few weeks ago, and we just kind of jumped into her research and didn't really talk about her position a ton.
Okay. Okay.
But I know that this is an area that she has done research in and is like continuing to do some research in, and it's been a little bit challenging in the current context to get grant funding for that research. And she's pushing ahead nonetheless because she is so passionate about it.
I would love the connection.
Yeah,
absolutely.
I'll send you all an email. Yeah.
I do have to jump off, but thank you, Lizzie, and nice to see you again. And I hope to meet up sometime in the future. Connect.
Absolutely. Good to see you, Federico.
See y'all later. Bye-bye.
Lizzie, is there an email you prefer that I use?
Yeah, I'll send you my let's do academic email. It's
Okay, I have your Gmail. I didn't know if you wanted
my Gmail.
Yeah. It might be helpful to have your school email.
It's the letter E, and then love, LOVE, number 1.
Love 1
at vt.edu.
Okay. love1 at vt.edu.
Perfect. Thank you.
Yeah.
Well, it looks like we can wrap up today if you would like. Thank you so much, Lizzie, for being here and sharing all this wonderful information. I look forward to seeing you again in the future and hopefully work on some things together. Congratulations on everything that you're doing in your doc program. And
thanks. Thank you. I appreciate y'all. Bye.